Hey guys, it's Ashley Dodds. I did my master's project on polycystic ovarian syndrome with an emphasis on infertility. I chose this subject because I'm interested in women's health, but I'm especially interested in infertility, and I also know many people who have been affected by PCOS. PCOS is one of the most common forms of ovulatory infertility. Its prevalence has been reported at about 6 to 10% of the population worldwide. It's a disease with an unclear etiology. Its primary features include ovulatory dysfunction, androgen excess, and/or polycystic ovaries. And one thing I learned while doing this master's project is that the ovaries contain immature follicles, and these follicles are not the same as ovarian cysts that might rupture or cause the patient pain. They are just immature and much smaller than a mature follicle that would typically be ovulated. Some high-risk groups for developing PCOS are women with ovulatory infertility, insulin resistance with or without obesity, type 1 or type 2 diabetes, a history of premature sexual maturation, a first degree relative with PCOS, Mexican American ethnicity, and the use of anti-epileptic drugs. The Rotterdam criteria are used to diagnose PCOS. This includes having two or more of the following: oligoovulation or anovulation, hyperandrogenism, or polycystic ovaries on ultrasound. Women with PCOS have an increased likelihood of infertility and spontaneous abortions. They have a 20 to 40% higher risk of spontaneous abortions than the baseline obstetric population, and this mechanism of the prevalence of pregnancy loss is very poorly understood. The physical exam in adolescents and adults with PCOS is slightly different, but you'll typically see most of the same things on physical exam, like hirsutism, which is a coarse hair that grows in a male pattern, and other signs of virilization like male pattern baldness, alopecia, increased muscle mass, a deep voice, and clitoromegaly. You may also see commonly irregular menses and acne because excess androgens stimulate sebum production. Many of these women will also have infertility issues. There are some metabolic signs that are associated with PCOS, like obesity and acanthosis nigricans, which is a velvety hyperpigmentation of the skin that results from insulin resistance. PCOS is a diagnosis of exclusion. However, there are some lab tests that will aid in the diagnosis. PCOS can only be diagnosed when other medical conditions that cause irregular menstrual cycles and excess androgens have been ruled out, like Cushing's, thyroid dysfunction, and hyperprolactinemia. For labs, one thing that you'll be looking for that's part of the Rotterdam criteria is an elevated serum androgen level. There's no specific level that's considered diagnostic of PCOS. You're just looking for an elevation of that number. You can also look for a mid-luteal phase progesterone level. This is used to diagnose anovulation, and you're typically looking for a level less than 3 or 4. This is another one of the Rotterdam criteria. Luteinizing hormone and follicle-stimulating hormone can be drawn, and that ratio is normally greater than 3 in women with PCOS. If you are specifically trying to determine the fertility status of a patient with PCOS, you'll need to do an ovulatory function assessment. As I talked about before, it's important to get that mid-luteal phase serum progesterone level 1 week before the menses is expected to occur. The most accurate method in determining ovulation is daily ultrasounds, but that's not practical and it's not done very often. For imaging, a transvaginal ultrasound is the most common thing done. There's specific Rotterdam criteria for those ultrasounds. An MRI can be used to visualize the ovaries in women who are obese and in whom the ovaries cannot be adequately visualized with ultrasound, and it can also be used in adolescents in whom a transvaginal ultrasound is inappropriate. There is no cure for PCOS, and the treatment is based on the patient's desired goals, including fertility, regulation of their menstrual cycle, and alleviation of symptoms. For general treatment, metformin is used often. It regulates the ovulatory cycle, it helps reduce resistance to insulin, it improves the lipid profile, and it increases the levels of sex hormone binding globulin. Recent studies have shown that it has a positive effect on the symptoms of hyperandrogenism like hirsutism and acne. If the patient doesn't wish to conceive, you can use oral contraceptive pills. They restore the rhythm of menstruation, they reduce hyperandrogenism, and they contribute to reducing the risk of endometrial hyperplasia. For patients who are struggling with infertility and who specifically want to conceive, the first thing that is done for treatment is lifestyle changes. So for these, you want the patient to lose weight with increased physical activity. You might try weight loss medications or calorie restriction. But the first line medical therapy to induce ovulation is clomiphene, which is a SERM. Recent studies have shown that there's an aromatase inhibitor called letrozole that could result in better outcomes, but it is not being used first line at this time. Second line treatment is gonadotropins, specifically human menopausal gonadotropin, HMG. It's used to stimulate ovulation. And if these things fail, some patients decide to undergo assisted reproductive therapy. In vitro fertilization is the most common type of assisted reproductive therapy. There is no way to prevent PCOS, but early diagnosis can help prevent complications and comorbidities and lessen the patient's symptoms. Some comorbidities and complications include dyslipidemia, coronary artery disease, obesity, diabetes, sleep apnea, endometrial cancer, infertility, and pregnancy complications. There's some close follow-up that should be done with your patients that have PCOS. If you're in family medicine, they need to specifically follow with an OBGYN, especially when they become pregnant. They will need close follow-up due to the common complications during pregnancy. PCOS is a very complex medical condition. It affects 6 to 10% of the population worldwide. With improvements in diagnostic tools and ongoing treatment research, we and other medical providers can more easily diagnose and better treat PCOS. Research has been especially promising for those patients with PCOS who wish to conceive, as there are new treatment options for infertility constantly emerging. Here are my references, and I hope you guys learned something about PCOS.